between this and this is iron. So whilst we understand that for a vitamin C depletion, this is more common in smokers. So every cigarette that a patient has can deplete your entire recommended daily intake of vitamin C, one shot. Does this mean your patient can't undergo procedures? Why not manipulate the situation? So if you were to now look at increasing vitamin C in diet and through supplementation, then we can positively influence our outcome. So with this process, the recommended daily intake, or the RDI of vitamin C, is 1,000 milligrams per day. But if your patient smokes, they're going to be deficient. So from a supplementary perspective, why not encourage your patient to support their procedures of any regenerative medicine procedure that you deliver with supplementation? I would suggest 250 milligrams of vitamin C per cigarette. If a patient overdoses on vitamin C, we call this vitamin C saturation. And this shows in the form of diarrhea. But if you are deficient in the first place from smoking, you don't reach that saturation point. So what we can do is now maintain, but also at the same time activate and stimulate our potential for collagen production. For iron deficiency, this is more common for females. The recommended daily intake is 15 milligrams. With this process, your highest naturally occurring source of vitamin C comes from berries, comes from kiwi fruit. Your highest naturally occurring source of iron comes from kangaroo meat, but it can also come from venison, it can also come from beef. For those patients that are vegetarian, be aware of supplementation, that the iron which is extracted from seaweed, wakame, it's not recognized by the body. So you need to be careful how your supplementation is recognized by the body to now promote tightened bundles of collagen protein fiber. The next consideration is communication. When you look at a patient who has post-acne scars, why is it that the post-acne scars are localized to certain areas on the face, but they don't have any post-acne scars on their neck, on their chest, on their knees, or on their feet? What we notice is when there's a period of damage and trauma, particularly following acne, what we see is the attack of what is called lipase enzymes. As the body undergoes its repair process, communication through cytokines, communication through RNA and DNA, then transcribes the blueprint of the skin, enabling for an effective and consistent healing response. What facilitates this healing response in the transcription of RNA and DNA between the fibers is the role of zinc. We all commonly hear that zinc is good for healing, but why? It's the role of a zinc finger. And the zinc finger facilitates the transcription of our skin's blueprint of RNA and DNA, allowing for a consistent healing process, allowing for regeneration of the correct message, reducing cicatricial healing, and allowing for a regulated collagen production. Males are more common to undergo a zinc deficiency by comparison to females. The recommended daily intake of zinc is 23 milligrams a day, and you may wish to consider increasing this for patients affected by acne, but also patients affected by post-acne scars especially. The highest naturally occurring source of zinc in food is found in shellfish. However, if we move down the supplementation route, we now see with this three-dimensional approach of simple considerations, vitamin C, iron, and zinc, we can now influence a positive outcome for collagen production. For those of you who are working with procedures which require activation of regulatory growth factors, that includes not just Dermapen, but that also includes PRP, that also includes nanofat, fat grafting, all of these procedures, some simple changes to the diet before the procedure will ensure and maximize better procedural outcomes. So my recommendation before any such autologous procedure for at least 2 weeks pre-op, we want to remove alcohol from the diet. We also want to remove trans fats from the diet. We also want to remove inflammatory foods. This is generally something of very high heat temperature or something that is of high spice or inflammatory temperature. What we also want to reduce is high glycemic index, so high sugar diets. Sugar is acid. Acid then attacks the binds. So what we find, particularly with sugar, is the process of glycation attracting to the collagen fibers. So we want low glycemic index. We then take into consideration what reduces inflammation, but what also supports the digestive system is the role of alkaline. So if we can re-alkalinize our system, we can reduce systemic inflammation, and we can now promote a more active macrophage. We can now promote a more active healing and regenerative process. So when the modern patient comes in demanding a revolution and renovation of their skin, these simple steps now enhance your process, not only of phagocytosis, but also your process of collagen deposition and placement. The third most dominant cell that we find in the dermis is an adipocyte, but it only accounts for about 5%. The epidermis is controversial. The medical market looked at microneedling in the 1990s and said, it's too superficial, nothing's going to happen. Let's give the epidermis to the beauty market, and the medical market will work everyone at 4 millimeters down here. This was all incorrect. The epidermis has high value. What I want to show is the most dominant cell that we have in the epidermis is the keratinocyte. The keratinocyte is responsible for 90 to 95% of cell composition. Keratinocyte found in basal epidermis undergoes the process of keratinization until a fully keratinized keratinocyte then sloughs off as a corneocyte. If your patient has milia, if your patient has keratosis pilaris, you don't have a problem with an adipocyte, you've got a problem with the keratinocyte. If your patient has acne, your patient does not have a problem with a fibroblast, they have an issue with the keratinocyte, and it's slowing down for retention hyperkeratosis. The third most dominant cell that we take into account is the melanocyte. The melanocyte lives here in basal epidermis. The melanocyte has these dendrite arms, and these dendrite arms communicate. So they then hand over the pigment capsule, which is called a melanosome. The melanosome is handed over into the keratinocyte in spinosum epidermis. So we understand for very precise pigmentation procedures, stratum corneum will not work, stratum lucidum will not work, but targeting down to reticular or targeting down to hypodermis is not your area of direct cell stimulation. The melanocyte only accounts for about 3% of cell composition, but it has and possesses immense power for influencing melanogenesis and our effects with hyperpigmentation, but also hypopigmentation. When the melanogenesis process, which is a topic we're going to explore in greater detail this afternoon, becomes pressured, arguably through an increase of estrogen, we now see the displacement of the melanosome and the melanin. In this case, it now falls into the epidermal junction and then falls into superficial papillary dermis. With this process here, you're not supposed to have melanin in the epidermal junction. You're not supposed to have melanin that's sitting in superficial papillary dermis. It's viewed as a pathogen. So this pathogen now becomes digested and processed through the macrophage. So when you have a pigment-containing macrophage, we're going to call this a melanophage. And particularly with melasma and with dermal hyperpigmentation, erythemus dyschromicum perstans, or ashy dermatosis, your problem isn't basal spinosum, but your problem is melanophages clustering in epidermal junction and in papillary dermis. Now that my map is complete here, I still never answered the question of, well, what depth? We look at this and we go, that's great, we can treat pigmentation, but what depth? That's great that you can treat scars, but what depth? Depth is not about arithmetic. Depth is not about a mathematical endpoint. Depth is about what you see. I'm going to link this into blood. There are no blood vessels in the epidermis. So if your needles touch into the epidermis, your complete visual endpoint is no blood. However, if your needles are just working so superficially that they're only touching stratum corneum, then your visual endpoint is no blood, but you'll note that there is no color change. Realistically, for an aesthetic procedure, you're too superficial. Nothing is going to happen. There is no benefit targeting these cornea sites. However, particularly for acne stage 1 or 2, familiar, for keratosis pilaris, where the keratinocytes is your problem, if you target into mid-epidermis granulosum, your visual endpoint is going to be no blood, pink skin. If you then go a little bit deeper, which is where you need to go, if you want to influence the relationship between melanocyte and keratinocyte, then you will see no blood, red skin. All you simply need to do is turn your needles up or turn your needles down until you achieve the perfect visual endpoint. When we look at vascular activity, it's focused around papillary dermis. We have smaller size vessels, but they're more frequent by comparison to the vessels in the hypodermis, which are larger in size, but also less frequent. For the epidermal junction and very superficial papillary dermis, where we see clustering of melanophages for melasma, for our dermal hyperpigmentation. You'll notice that the blood vessels are horizontal, but you also have these little vertical ones here. So to guarantee that you are interacting exactly with the melanophages, you need to be targeting these vertical vessels, which means that your visual endpoint is just the occasional pinpoint blood, not consistent, just occasional. But once your needles target down to the horizontal vessels, it's then consistent pinpoint blood. Consistent pinpoint blood is your visual endpoint to guarantee that your needles are interacting where you have your highest composition of fiberglass. This is a minimum for your scar procedures, for your collagen induction, for your anti-aging, for your wrinkle reduction, for your stretch marks. You must see pinpoint blood as a minimum. For an easy visual endpoint, if the scar that you see has a red, blue, or purple undertone to it, then visually this means that you can see that there is some vascular activity in the dermis. So that means that for red, blue, purple scars, you can look for pinpoint blood. If the scar is very white, or for a darker Fitzpatrick, it's dark brown or black, that is a sign that this vascular activity either doesn't exist, particularly for a burn contracture, or has been pushed down, or due to irregular healing, is in a zigzag shape. So the only time you need to go down to the hypodermis for scar revision is for very old, very white, or very dark scars. To ensure your visual endpoint that you're targeting these large vessels, you're looking for moderate blood. So you're looking for drops of blood coming through. So everything you need to know first, what is your indication? What is the pathophysiology of that indication, and which cell has gone wrong? Where does that cell sit within the skin, and how do I then tie that into a visual endpoint? My visual endpoint will either be no blood, pink skin, no blood, red skin, the occasional pinpoint blood, consistent pinpoint blood, or moderate release of blood. Your moderate release of blood will also link in where the follicular bulb is then in position and receive nutrients, hormones, and growth factors, so your alopecia procedures, in addition to your older scars. But if you also consider issues such as cellulite or a herniation of adipose tissue, this is going to be your ideal end point. So the simple process here has achieved two things. First, we understand that visual endpoint is more precise than creating a mathematical endpoint. We also understand that depth is not about arithmetic, it's about what you see. But this also maps up for us the indications that we can successfully treat with Dermapen 4. When your process of keratinization becomes malfunctioned, you're going to see issues of retention hyperkeratosis, which will then relate into the conditions of acne, but also relating to issues such as milia and keratosis pilaris. You can safely treat acne stage 1 comedonal, stage 2 papulopustular, and stage 3 nodular cystic. Hold on, am I not going to be then spreading Cutibacterium acnes all over the face, and I'm going to make the issue worse? Let's review. Cutibacterium acnes is anaerobic. It lives and thrives in the sebaceous gland. If you take a fish out of water, it suffocates, it asphyxiates, it can't breathe. If you then add with Dermapen 4 at top speed, 1,920 microtons per second, you deliver oxygen. That suffocates your Cutibacterium acnes, and then its degradation, its reducing, forces further reduction of associated Staphylococcus epidermidis, which allows for a unique innovation that is antibacterial and antimicrobial. I don't recommend you treat acne stage 4. But for our acne familiar for keratosis pilaris, we're aiming for the keratinocyte. So your visual endpoint is either going to be no blood, pink skin for milia, keratosis pilaris, and for comedonal acne. And in the case of papulopustular or nodular cystic acne, you would look for no blood, red skin. Of course, as you Dermapen over the top of an active papule or pustule, you will see some localized blood. Not a problem. So long as the full face is not completely covered in blood, then you can guarantee that your needles are working where they need to be. For hyperpigmentation that is epidermal, the imbalance or the pathophysiology is the breakdown of the relationship between the keratinocyte and the melanocyte. The melanocyte resides in basal epidermis, and then the handover of the melanosome is in spinosum. As such, your visual endpoint is no blood, red skin. And this works successfully for facultative hyperpigmentation, for the treatment of lentigines or age spots, for the treatment of ephemerides, and for many forms of post-inflammatory hyperpigmentation. But in the case of dermal deposition of the melanophage, you will need to work a little bit deeper, which means in the epidermal junction or superficial capillary dermis. And as such, you will look for the occasional pinpoint blood for melasma, for pigmented poikiloderma, for erythematous chromic perscans, for ashy dermatosis. If we see an imbalance of the relationship and a failure between the melanocyte and the keratinocyte that results in the overproduction of hyperpigmentation, when that relationship stops, then we can see hypopigmentation. So this is the same area, no blood, red skin, that we target in the epidermis for our hypopigmentation, including ultraviolet aggressive hypomelanosis, moving into treatment of post-inflammatory hypopigmentation, and then with drug combination therapies, we can successfully treat chemical leukoderma, and with drug combination therapies again, vitiligo vulgaris, and also acral vitiligo. But for all of these indications, no blood, pink to red skin, with the exception of dermal hyperpigmentation, which is the occasional pinpoint blood. If you want true collagen induction therapy, you need to draw pinpoint blood as a minimum. If you don't draw blood, then this is a sign that your needles are not directly intervening with the fibroblasts at 85% composition within the dermis. As such, you will need to draw pinpoint blood as a minimum for your anti-aging procedures, right of production. You will need to draw pinpoint blood as a minimum for your post-acne atrophic scars, rolling scars, boxcar scars, ice pick scars. For your pockmark scars following chickenpox, syphilis complications, again, you will need to draw a minimum of pinpoint blood. For newer scars, which have a red, blue, or purple undertone, this is also your area for hypertrophic, and also your area when you have a controlled and prepared keloid scar. I will reveal the protocols for keloid scars as our last topic for today. If we can treat scars with a minimum of pinpoint blood, particularly if they're newer, we also treat within the dermis with pinpoint blood for treatment of striae. This includes striae distensae, striae atrophicae, and striae gravidarum. Where we also influence the vascular activity are unique innovations for rosacea and telangiectasia. If visually you can see a patient's capillary network on their skin, then you can see all the way through their epidermis, and you can start seeing down to superficial capillary dermis. Your patient has not got density. Your patient has a very, very thin skin. So if we can activate collagen and redensify the dermis, but through the release of regulatory growth factors, we can now promote a balance for epidermal integrity, then we can treat and target telangiectasia, but we can also deliver a unique innovation for stage 1 erythema to telangiectatic rosacea, stage 2 papulopustular rosacea, and for stage 3 phymatous rosacea, where we see rhinophyma. But you may require a drug combination therapy for this. If a patient is undergoing just some mild hair thinning, you can look for some pinpoint blood as part of combination therapy. But for true alopecia conditions, you will require more blood. So everything you see here, you are looking for pinpoint blood as your procedural endpoint. The only time you ever need to draw lots of blood is for older scars and for older striae. So if it is very white, alternatively if it is dark brown, or if the scar is black. Otherwise, the other time that you will need to deliver down into the hypodermis is for your alopecia procedures. You will require a facilitating combination therapy, which may include PRP, or may include an appropriate drug therapy or mesotherapy. And as such, we see success for tractional alopecia, moving into the early stages of cicatricial alopecia, and then moving into conditions such as alopecia areata with drug combination therapy, telogen effluvium, and also for androgenetic alopecia. We can also see success for cellulite, and our visual endpoint is going to be lots of blood. Now that we've established that death is a visual indication, and understand that the indications we see are based on the direct intervention of our needles with the cell, we can now explore how frequently we perform treatments. The body's wound healing response is defined by 5 key cascades. Hemorrhage, blood rushes through to the treatment area. Hemostasis, blood seals off. And then our 3 traditional phases of inflammation, proliferation, maturation. Each of these subcategories and stages have their own time period that biologically they are allocated. If we work in with this biological time, then we can support the skin's wound healing response. If we work against this biological time and promote multiple wound healing responses simultaneously, then the skin's reaction is to create chaos. And chaos equals scars, but chaos also equals post-inflammatory hyper or hypopigmentation. Inflammation is defined by 5 key features. We undergo a microtrauma, but blood does not need to be drawn. In Latin, we have dolor, calor, rubor, tumor, functio, laesa. but pain, heat, redness, swelling, loss of function. The inflammatory response can be activated without having to draw blood. And we see two key phases. First is phagocytosis. As part of chemotaxis, we see the white blood cells, the macrophage, the neutrophils, then sitting and sticking to the capillary wall. They begin to roll, the capillary wall now becomes permeable, and the phagocytic cells can work their way up and out, reducing and removing pathogens. The second key step of the inflammatory response is the release of regulatory growth factors. By comparison to regenerative procedures such as PRP, such as nanofat, the figures aren't always exact because it's based on patient's health. But we understand that for the average healthy patient, a Dermapen 4 will increase growth factor potential by about 3 to 5 times from baseline. With the release of these regulatory growth factors, this is what now instigates quality control, functionality, integrity, balance of the skin. Whilst we could discuss thousands upon thousands of growth factors, I want to talk about 7 key growth factors that you need to know. The big boss of everything that occurs within the epidermis is epidermal growth factors. What manages the process of keratinization, but what also enables a direct communication to fibroblast growth factor is keratinocyte growth factor. It manages keratinization. What determines too much pigment by comparison to what's not enough is melanocyte growth factor. The big boss of all processes within the dermis and within the hypodermis is called transforming growth factors, a large family. What stimulates the correct type of collagen, the form, the placement, the development, its maturation, is fibroblast growth factors. And then what manages our process of angiogenesis, growth and development of new capillaries, is vascular endothelial and platelet-derived growth factors. If these processes can all be released as part of an inflammatory response when no blood is drawn, and if the inflammatory response is biologically resolved within 14 days for a chronic inflammatory response, then this now dictates that the safe parameters for your more superficial Dermapen procedures, epidermal, no blood, but you can treat as frequently as every 2 weeks. If your patient cannot afford that, then you can stretch that out to every 3 to every 4. So if there is superficial, no blood, these procedures may be performed safely on all skin types and conditions as often as every 2 to every 4 weeks. The proliferative wound healing response is where we activate microtrauma into the dermis, and this is where we see collagen placement, but where we also activate angiogenesis. With the proliferative response, this is our body's biological response to major trauma. For a moment, I want you to imagine that I am a caveman and there's dinosaurs, and I get attacked by a dinosaur. Work with my stories. If I get attacked and I have a big gash down my chest and shoulder here, in caveman times, there's no doctor, there's no hospital, there's no pharmacy, there's no product you can put on. What are you going to do? Scar tissue. So the process of cicatricial healing here is a risk for every skin, of every ethnicity, of every age. This is our biological response to major trauma. And the placement of scar tissue, cicatricial, which is the Latin for upside down, sees the overproduction of collagen to rapidly re-epithelialize where there's major trauma. Whilst anthropologically this is a benefit, aesthetically this is not attractive. What we activate and stimulate with the Dermapen 4 procedure is a scarless wound healing. And this is all achieved without heat and without ablation. Dermapen will activate the release of immature type 3 collagen, which will take up residence where the trauma begins, and then we see the role of epithelial cells to re-epithelialize more superficially without scarring. The pros and cons. The benefit, there's no scar, but the con is that you have immature collagen. There's no structure to this. However, over a 6 to an 8 week time period for the average adult, we then see the development and the maturation of this collagen from the immature type 3 to now the structural and durable type 1. And we can achieve this process of scarless wound healing without the heat, without the ablation, and a fractional rejuvenation utilizing Dermapen 4 needles. When you burn, when you attack, when you ablate, when you over-traumatize, when you create multiple wound healing responses, you create trauma and chaos. This then activates what we call bad growth factors or profibrotic growth factors. Transforming growth factors beta 1 and 2 and heat shock protein 47. When these get released, this is when we see scar tissue, and we see an imbalance of melanocyte growth factor, which means post-inflammatory hyper and post-inflammatory hypopigmentation. So the importance of our Dermapen procedures works in with the body's healing and regenerative response. And because this sees collagen reformation in a 6 to an 8 week time process, this now means that we are able to treat where we draw blood here as often as every 6 to 8 weeks, no sooner. If you start drawing blood more sooner, you risk multiple wound healing responses, which equals chaos, which equals scars. With this process, this now determines that if you're going to work more into the dermis, into the hypodermis, then for these procedures, you will treat these as frequently as every 6 to 8 weeks. What's within the dermis? Pinpoint blood every 6 to every 8 weeks. For your hypodermic indications, moderate blood every 6 to 8 weeks. So with this process, we now work in with our biological cascade to understand how we can successfully develop our indications, understand that microneedling with Dermapen 4 is not about mathematics, it's about what you see, but now also creating standard treatment protocols and frequency of procedures without the risk. What your patient gets out of this is everything a modern patient wants. A fast procedure, a procedure that does not necessarily require topical local anesthetic, a comfortable procedure, a procedure that can be treated in only 3, 4, 5 minutes for the face, and a downtime of just a sunburned skin in appearance and sensation for 1 to 2 days following the procedure. The patient can undergo their procedure and leave the clinic immediately. With the DP Dermaceuticals Cover Recover SPF 30 PA++ camouflage, this will immediately disguise any post-operative redness, protect the skin, but with a silicone network of 3 silicons and a probiotic, it accelerates the wound healing, accelerates repair, and supports the skin's microbiome. We also understand that just through our simple process of mapping out the skin, that Dermapen is more than just scars. Dermapen is more than just wrinkles, it's more than just striae. We can now see anywhere up to some 70 indications in corrective, but also in aesthetic medicine. And when we see our patient as frequently as every 2 to every 4 weeks for superficial, every 6 to every 8 weeks for our deeper, we have a very profitable procedure, but a unique procedure that targets the quality, the integrity, the texture, the tone, and the health of the skin to support all of our other treatments. A couple of considerations. Our contraindications are more about an active health condition. However, if it is in inactive phase in remission, you will be able to treat. So we understand that some of the most obvious areas for undiagnosed lesions, actinic or solid keratoses, pre-skin cancers, please get these checked out. However, for autoimmune conditions from vitiligo to lupus to scleroderma to psoriasis, so long that it is inactive and has been stabilized for at least 6 months, we are able to successfully treat. We understand that conditions such as collagen vascular disorders, Ehlers-Danlos syndrome, Marfan syndrome, you will be in communication with the patient's doctor and medical provider to determine when you can perform safe treatments. But otherwise, if there's any active bacterial, fungal, or viral infection of the skin, wait for that to clear and your patient will be suitable for the Dermapen 4 combination therapy. For considerations, there are expert and advanced protocols that enable you to successfully treat with filler, with botulinum toxin and Dermapen 4 in a single procedure. You understand that your botulinum toxin is intramuscular. Your filler is subcutaneous and your Dermapen is working higher. So you can see that there's no intervention in this case. But otherwise, for simplicity, if your patient has any allergies to anesthetic, if your patient has any heart conditions, you don't need topical local anesthetic with the Dermapen 4 procedure. It's operating so fast that you activate a vibration therapy. Likewise, also with your patients, I would suggest that you avoid acne stage 4. And if your patient has undergone any recent laser, any medium depth chemical peels, and any other treatment that requires recovery, you will wait at least 2 weeks either side, and then you can perform safely your Dermapen World procedure. How we're now going to create the ultimate of Dermapen 4 and microneedling is with new innovations and developments with DP Dermaceuticals MG collection. The MG collection is now a revolution of chemical regenerative medicine. Your Dermapen 4 works and activates through mechanical regenerative medicine. So with 1,920 punctogenous per second into the skin, we activate the body's wound healing response with controlled growth factors, with regulated collagen deposition and angiogenesis. Now we're going to use a chemical regenerative response with the new DP Dermaceuticals MG collection to now physically feed and to now activate further responses within the skin to treat and target pigmentation, acne, collagen modulation, tensile strength, volume, density, and the health of the physical skin. And this is the new MG collection. The MG collection is the biggest product research and development that we have created to now facilitate the ultimate of mesotherapy infusion into the skin. The MG collection will now take over from your original DP Dermaceutical combination therapies. Traditionally, all Dermapen 4 procedures are facilitated and activated through the combination of hyperactive plus either your choice of bright light, antioxidant cocktail, or retroactive. The MG collection now takes over our original technology to now deliver the ultimate of active concentration with a dual delivery system and with sterile 5cc vials. With this, each vial can work individually, but you also have the capability to add with a Luodot syringe to mix and match your own blends. The advantage of this dual regenerative aspect, the mechanical revision with Dermapen 4, but now your chemical revision with the MG collection, is achieved through our Hyla-fused hyaluronic acid. Under normal circumstances, despite what we see with Instagram influencers telling us, despite what the average patient understands from social media, from the newspaper, from magazines, human skin is not a sponge. So there is no surprise that when we look at the biopsies and you apply an aqueous solution onto the skin's surface, that the human skin does not absorb that liquid down to the lower layers. This does indeed make the concept of deep cleansing redundant. This does indeed make the concept of a moisturizer that disappears into my skin redundant. Where did it go? Because it didn't go down to the bottom layers of your skin. What I want to show here is a comparison of the success of your automated microneedling with Dermapen 4. When we compare topical application to an intradermal injection, the basis of mesotherapy, the basis of PRP infusion and drug activation in a medical aesthetic clinic is the injection. The injection in this case, irrelevant whether that is a single needle, nappage or point-by-point technique, or whether that is a mesotherapy injector gun or handpiece, when we compare the technology with Dermapen 4, which delivers an unprecedented 1,920 puncture channels per second, Dermapen 4 shows us unique, advanced innovations. Traditional injection technique looks like so. We see where the needle goes in, we see where the plunger has been pushed, and a small bolus or collection of product within the skin. We never assumed that microneedling would be able to rival the traditional injection. Primarily, when we considered dermal rollers, that the solution would go in, but as the barrel turned of the dermal roller, it would then remove the solution. We also assumed that because the needle is hollow within an injection, but the needle is solid with automated microneedling, that somehow the solution would not get in. This third biopsy is Dermapen 4 technology. At a depth of only just 1.5 millimeters with multiple passes, you can see that with 120 revolutions per second top speed, creating 1,920 puncture channels per second, the mechanics, the physics of the needles will physically push and force an active ingredient, substance, or product into the skin. But with 2,000 puncture channels per second, by comparison to an injection, which may be 1 to 7 puncture channels per second, we can facilitate, administer, and distribute an active substance into the skin with far greater capability and with far greater potential. Understanding this process and understanding this level of infusion, the blend of Dermapen 4 plus the MG collection marries and combines the ultimate of two regenerative procedures. Your mechanical activation with Dermapen, your chemical rejuvenation with the MG collection. But this process also opens up unique opportunities and new innovations for how you administer PRP, how you administer nanofat, but new ways for drug distribution, even including mesobotulinum toxin into the skin. It's faster, it's quicker, it's more comfortable, it's injection-free, and it distributes your product with far greater activation than you see with the injection. And as identified by world-leading dermatologist Sultani Aramshaki based in the USA in 2014, this is the ultimate of transdermal delivery. Sultani Aramshaki also noticed that you can't just put anything into the skin. Just because you can doesn't mean that you should. And what she observed in 2014, that when practitioners were microneedling in solutions designed solely for topical application, these solutions were not designed for infusion or for the release within the skin. In this case, she produced a clinical where 70% of patients who had a standard topical vitamin C serum infused into their skin all came out with granulomatous reactivity. So again, just because you can doesn't mean that you should. What you need to understand is that how we can promote our microneedling procedures is now through safety. And this is what the MG collection delivers and surpasses, now with the highest concentration of actives. If you do not understand the concept of molecular weight, this is an area for discovery. If you force something of large molecular size into the skin with needles, it can't go up, it can't go down, it can't go sideways. It gets stuck. This is granulomatous reactivity, as we see here with one of Sultana of Shahi's studies. Likewise also, if a product is designed for topical application, its molecular weight is going to be large. So there is a very big difference between something that is designed to be injected or something that is designed for infusion and activation within the skin. We understand that active ingredients come in many different pHs and chemical forms. Vitamin C, as an example, in its purest form, ascorbic acid, a pH of 2.2. If you infuse that into the skin, you will create carpaccio. The low pH will cook the skin, and this is what we see. If you have the wrong chemical form of an active ingredient, then you risk burning the skin. Take into account retinoic acid or tretinoin. There's a benefit when you apply it topically, but if patients experience a retinoid reaction through topical application, you can imagine the response when it's a systemic application. This is where the DP Dermaceuticals MG collection excels. 5 cc's of sterile solution, ensuring a triple molecular weight down to 10 kilodaltons of size, ensuring efficacy, concentration, and durability. This is now your effective mesotherapy. Your procedure will glide, but now the ultimate of 2 regenerative components added together to maximize your Dermapen 4 procedures. With the 5 ml vials, we now no longer need to mix and blend your hyperactive with your traditional bright light retinol active or antioxidant cocktail. However, the versatility of the MG collection means that you can actually mix and blend multiple bottles together to customize further what you see, the response to which you create, and the indication that you are physically treating. The vials and the product can be safely used for face, body, scalp, and even for intimate rejuvenation. We see new trends for hyperpigmentation in the axillary and hyperpigmentation around the outer labial area. What we now also see is a dual delivery system, which increases the concentration, the stability, but the time release of the active agents within the skin. Your Dermapen procedures will serve as a perfect glide when administered with the MG collection, so that the full face will still only take 3 minutes, 4 minutes, 5 minutes. They deliver the ultimate of comfort with up to 35 milligrams per milliliter of triple molecular weighted hyaluronic acid, and now serve as new methods to facilitate PRP, injection-free treatments, drug infusion such as mesobotulinum toxin, but now delivers versatility as an individual component, but also when mixed blended. There is no risk of vascular occlusion, there is no risk of bruising, there is no injection with these, but the ultimate of delivery system. Each technology is non-cross-linked, ensuring that there is no risk of granulomas. Now, with new parameters, with new protocols, MG collection plus Dermapen 4 equals new potential for all patients and procedures. All corrected DP Dermaceuticals products, including the home care, the MG collection, and all in-clinic products, contain the exclusive and patented high-diffuse hyaluronic acid. This is a triple molecular weight of non-cross-linked hyaluronic acid technology. The research and development for this from the Matrix Biology Institute in the USA, the world's leading development agency for medical-grade hyaluronic acid, was studied independently by Monash University in Melbourne, Australia. Their conclusion was that the small and medium molecular weight, when applied to an intact human forearm, no microneedling, no injection, no other intervention, the medium and small molecular weights penetrate through the skin's acid mantle, and we see residence in basal epidermis with just topical application after a 20-minute time period. The biopsy further shows that the smallest molecular weight at 10 kilodaltons takes up residence in reticular dermis. As a standalone ingredient, the high-diffuse hyaluronic acid not only activates hydration and a reduction in inflammation, but down to 10 kilodaltons of molecular weight serves as a unique encapsulation system to deliver other ingredients with deeper and greater efficacy into the skin as part of the Dermapen 4 procedure. As a world first, only Dermapen World possesses this technology up to 35 milligrams per milliliter, making this the highest concentrated non-cross-linked hyaluronic acid product in the global market. Now with the versatility to increase lubrication and comfort during the procedures, but for further stabilization of other active ingredients within the skin, the MG collection is the pinnacle of meso-glide combination therapies. With origins too in the mesotherapy and the filler market, calcium phosphate, otherwise known as hydroxyapatite or hydroxylapatite, is now reformulated and reinvented with calfosome technology. Calfosome technology harnesses the calcium phosphate to now serve as a unique delivery and stabilizing system, particularly for oil-soluble ingredients, especially retinoids such as retinaldehyde. What we see with this micro sponge is an organic aspect of both calcium and phosphate, which allows for the drawing and holding of other ingredients, but the penetration through the skin's acid mantle and stratocorneum. As a standalone delivery system, this promotes further infusion of actives into the skin, even when topically applied as part of patient home care. But as a synergistic approach with the high-diffuse hyaluronic acid, as part of the Dermapen World in-clinic procedure, both high-diffuse and calfosome technology now enhance the stability of active ingredients, but their release and stabilization and preservation within the skin. This is a non-reacting or inflammatory technology. It is non-liposomal. It is also a non-polymer delivery system. As identified by Van Logem in 2015, we understand that the calcium phosphate delivers a stimulation also for fibroblasts and collagen deposition, but also activates the release of lamellar granules. This in turn promotes further release of free fatty acids and ceramides to reinforce barrier function, but to deliver oil-soluble ingredients within the skin. Again, there is no risk of granulomas, no risk of vascular occlusion, and the ingredient simply degrades into a calcium and into a phosphate ion, allowing for an organic, natural process to support skin functionality and skin health. This exclusive complex of delivery and stability is available in 2 of the premium MG collection products. forefront of global aesthetic technology, Dermapen World now harnesses a Nobel Prize award-winning new substance that is known as geranyl bisopropanol. The GGP falls under a larger umbrella that is called telomere technology. A telomere is a repetitive nucleotide that's found on the end of chromosomal strands. It's a lot like a piece of string. When we're born, our piece of string is about 11 kilobases long. But as it undergoes replication throughout our life, around about 2,500 times, the piece of string becomes shorter and shorter and shorter. So in old age, about 4 kilobases long. The role of the telomere as a youth code promotes and transmits RNA and DNA, but also preserves the chromosomal strands. The geranyl isopropanol technology, or GGP, promotes a preservation of the telomere with a unique approach like no other, allowing for new innovations, particularly for collagen revision and modulation. And as such, this exclusive technology features in the MG collection HA35 and serves as one of our most premium solutions for collagen induction therapy, writing production, scars, and also the treatment of striae. Your solution for hyperpigmentation to this date has been use of the DP Dermaceuticals Hyla Active plus the DP Dermaceuticals Bright Light. To now supersede this technology, we have the MGBL. The MGBL offers new avenues to intervene the melanin synthetic pathway at all 6 points, with a blend of tranexamic acid, of kojic acid dipalmitate, sodium ascorbyl phosphate vitamin C, licorice. This now promotes a tyrosinase inhibition, a melanosome transfer inhibition, prevents tyrosinase degradation, but activates as a redox agent and a peroxidase inhibitor. This is a new approach to all forms of hyperpigmentation, but particularly for new innovations for revision of melasma and dermal hyperpigmentation. The MG Collection BL features a base of 10 milligrams per milliliter of the hyalofused hyaluronic acid. So this means that the product in itself does no longer require you to use the Hyla Active. You don't need to blend this in to activate. The MG Collection BL already has the Hyla Active built into it. With this potent blend at a pH of 6, it cannot burn, it cannot irritate, but now delivers a new generation of intervening systems for treatment of all forms of hyperpigmentation. With a potent blend added and supported with copper peptides, the subsequent release of superoxide dismutase ensures long-lasting results and protection and reduction of the inflammatory response, contributing to the hyperpigmentation. The melanogenesis process is complex, but what we understand is from signaling from the pituitary gland to melanin-stimulating hormone and the subsequent action to tyrosinase, tyrosin, L-DOPA, and L-dopaquinone and phosphates is each aspect and each step requires an individual interception to prevent the overall signaling. In conjunction with daily application and reapplication of a sunscreen, the DP Dermaceuticals Cover Recover, the MG Collection BL now unlocks new opportunity and potential for your in-clinic Dermapen procedures to intervene all aspects of melanogenesis. The new addition of tranexamic acid into our technology promotes a reduction in both red macular pigment and treats and targets melanophages clustered around the vascular activity in superficial papillary dermis. What we also see with tranexamic acid is a reduction in overall inflammation. Now this new approach, in conjunction with kojic acid dipalmitate, in conjunction with sodium ascorbyl phosphate as a stabilized vitamin C, we now see the intervention, the interaction to create safe treatment of both epidermal but also of dermal hyperpigmented conditions. The suitability of the MG collection BL for all ethnicities, for all skin types, but particularly for recalcitrant melasma, delivers a stability and a procedural reliable outcome. For all hyperpigmented procedures moving forward, you will use the MG collection BL for treatment of uneven skin tone, for treatment of melasma, post-inflammatory hyperpigmentation, for intimate, for axillary rejuvenation, and for treatment of facultative ultraviolet egressed lentigines and sunspots. Your traditional combination for the treatment of acne has been the DP Dermaceuticals Hyperactive blended in 50-50 ratio with the DP Dermaceuticals CLR lotion. Now, the MG Collection CLR promotes a new approach that is antibacterial, antimicrobial, promotes microexfoliation, and reduces inflammation and post-acne red macules and post-acne hyperpigmentation. The MG Collection CLR revolutionizes acne treatment with the addition of an oligopeptide 10. We understand that Cutibacterium acnes is anaerobic. With the Dermapen procedure with an unparalleled 1,120 puncture channels per second, this now promotes an oxygenation into the follicle, which then encourages the process to force the reduction of Cutibacterium acnes, and then in turn, this promotes the reduction of associated Staphylococcus epidermidis. Now being able to infuse into the skin a oligopeptide 10, which is specific for Cutibacterium acnes, we now deliver an antibiotic and antibacterial response with greater efficacy into the skin. We understand that the acne condition is multifactorial. In addition to disinfecting, we also need to reduce the associated retention hyperkeratosis or clogging and congestion. Utilizing a pyruvic acid, this delivers a gentle approach to extrude congestion, but without the risk of burning the skin and without the risk of causing post-inflammatory hyperpigmentation. There is suitability of the MG Collection CLR for all Fitzpatrick skin types and ethnicities. Further features reduce the associated inflammation, which becomes activated by the release of lipase enzymes, and the versatility of this is achieved through both copper peptides, but also tranexamic acid and niacinamide. Niacinamide promotes further regulation of sebum quality, but what we also see is niacinamide and tranexamic acid plus kojic acid dipalmitate working, treating, and targeting any post-inflammatory hyperpigmentation, both brown but also red macular hyperpigmentation. The successful combination of the MG collection CLR with Dermapen reduces bacterial proliferation, promotes a reduction subsequently in inflammation, delivers a microexfoliation to reduce retention hyperkeratosis that now ensures a reduction and safety for post-acne macular and post-acne hyperpigmented scars. The MG Collection CLR is now your new Meso Glide that will successfully treat and target acne stage 1 comedonal, acne stage 2 papulopustular, and acne stage 3 nodular cystic. You could also use this as a synergistic solution for the treatment of keratosis pilaris and the reduction of milia. The MG Collection RAS is our new solution to reverse aging and scars. We revolutionized technology with retinaldehyde with the retinal active. This revolution delivers a medical grade vitamin A that does not create photosensitivity, that does not create photoinstability, and is perfectly tolerated by all skins. It delivers the same clinical benefits as tretinoin without the complications. The MG Collection RAS now delivers twice the concentration of retinaldehyde and now delivers a new innovation. So for the treatment of scars, for the treatment of anti-aging and deep wrinkles, and for the revision of striae, no longer do you need to blend your hyperactive plus your retinal active. Now we have a new innovation with the MG Collection RAS. As with all MG Collection products, they all contain the base of hyper-fused hyaluronic acid. This means that you don't need a hyperactive. So the products individually will still serve as effective gliding mediums. Lubrication equals comfort. Lubrication promotes speed of treatment, but lubrication also facilitates better infusion of the treatment actives. With now twice the content of retinaldehyde, we now approach new innovations for collagen modulation. This is further supported with pentapeptide 18. For acceleration of wound healing, the botanical extracts of trichroside, but Centella asiatica, also known as tiger grass, promotes rapid re-epithelialization. The presence of copper-peptides synergistically release superoxide dismutase, allowing a peroxidase inhibition, but also allowing for antioxidant protection and accelerated wound healing. Understanding that post-inflammatory hyperpigmentation is common for many patients following trauma and scars, the addition of shiitake mushroom delivers a unique tyrosinase inhibition. The vitamin A story began in the 1960s with developments and studies of the father of modern dermatology, Albert Bigman. The vitamin A technology then moved into new innovations of synthetic retinoids, discovered and created by Fulton in the 1990s. This is now being taken and further researched and developed by Credy and Vienne into retinaldehyde. The advantages of retinaldehyde, as studied by Credy and Vienne, is that head-to-head, retinaldehyde at 0.1% will mimic and equal the effects of prescription-grade retinoic acid, or tretinoin. However, the benefits of this are achieved without irritation, without photosensitivity, without photoinactivity when the patient goes outside, and without the retinoid reaction. This now means success and suitability on all Fitzpatrick skin types and all ethnicities, but also safety without extending downtime, and without burning the skin for your dermal and hypodermic indications. The further benefits we see with retinaldehyde is that it promotes a thickening of both dermis and epidermis, and we don't see the thinning as often associated with either retinol or alternatively retinoic acid. Head-to-head with cosmetic-grade retinol, we see some 200 to 400 times more power and some 20 to 40 times more concentration, delivering the ultimate of retinoid technology without the complications and without the retinoid reaction. The DP Dermaceuticals MG Collection RAS, in conjunction with the Dermapen procedure, promote, particularly via the release of fibroblast growth factors, new innovations and modulation for collagen, allowing for correction of scars, deep rhytids, and striae without the downtime and without the complications. These are new innovations of vitamin A technology. The MG Collection HA35 is a revolution of hyaluronic acid concentration. Based on the triple molecular weight of hyalofused hyaluronic acid, containing large molecular weight at 1,800 kilodaltons, medium at 1,600 kilodaltons, and small molecular weight at just 10 kilodaltons, we now promote and support transdermal delivery even without the microneedling. The MG Collection HA35 contains an unparalleled 35 milligrams per milliliter of hyalofused hyaluronic acid. This is 3.5 times the concentration by comparison to the original Hyalactive. Now with reinforced zinc and reinforced sodium ascorbyl phosphate as a stabilized vitamin C, but panthenol, the activity, stability, and time release of this MG collection is further enhanced with the calphosome calcium phosphate technology. The MG Collection HA35 can be blended in with any of your other MG Collection solutions, and this will increase your hyaluronic acid content. It is non-cross-linked. It is BDDE free. But what it also does is increases your stability and increases your delivery mechanism with the calphosome technology. So you can now upgrade your procedures by blending in the MG Collection HA35 in with either the MG Collection BL for pigment and for skin redensification, with the MG Collection CLR for acne and for scar treatment, or the MG Collection RAS for a dual volumizing and redensifying effect. Of the 35 milligrams per milliliter, 29 of these are small molecular weighted hyaluronic acid, ensuring the ultimate of infusion, but stabilization of the other active ingredients. This now promotes longevity when combined in with the calphosome technology. The MG Collection HA35 can be used as a light base to activate PRP. So no longer do you need to inject the PRP, you can infuse the PRP with your Dermapen 4 device. The MG Collection HA35 will not oxidize the PRP. It will further promote and enhance its delivery, but its stability within the skin. As part of advanced innovations, which I unfortunately don't cover today, the MG Collection HA35 can also be used to reconstitute botulinum toxin to now deliver new innovations for mesotox procedures. The MG Collection HA35 Plus is our revolutionary and most premium, prestigious product contained within the MG Collection line. If you are not sure which MG Collection for which indication, I recommend the 35 Plus. Likewise, for the most volatile of complexions, from telangiectasia to rosacea, but also to big plump, to big contour for the most aged of complexions and most damaged, the MG Collection HA35 Plus delivers the ultimate of concentration and versatility. This is the only product containing the telomere technology, and as such, this promotes, in conjunction with retinaldehyde, an intensive approach to collagen remodulation. With a base of 35 milligrams per milliliter of triple molecular weighted high diffuse hyaluronic acid, the MG Collection HA35 delivers unparalleled concentration without risk of granulomas and to promote the ultimate of hydration. With retinaldehyde, telomere technology, but also a host of vitamin A and vitamin E esters, we now deliver a combination of redox agents and antioxidant protection for the skin. As with the MG Collection HA35, with 29 milligrams of small molecular weight hyaluronic acid, this ensures not only a transdermal delivery when applied topically, but this now promotes the ultimate of stability for oil-soluble and water-soluble ingredients when combined in as part of an infusion with a Dermapen procedure. As such, the HA35 Plus can also be blended, mixed, and matched with any of the other MG Collection products to either increase hyaluronic acid, to add in the benefits of retinaldehyde, to deliver new innovation with telomere technology, but to also promote versatility to treat and target pigment and scars, to treat and target acne and thinness, but to promote volume and redensification for the skin. We now see twice the strength of vitamin A by comparison to the original retinol active, and 3.5 times size the concentration of hyaluronic acid as by comparison to the original Hyalifuse Hyla active. And as such, the MG Collection with just 5 simple products promotes new innovations for meso infusion. There are 4 options to administer. You can either distribute